celebrate the small wins. Well, so just building on what we heard from Laura, right? There is significant trends in health equity. And when we think about our first panel, we're focusing on resilience, and we're going to start off by thinking about what's happening in the world. So right now, the risk of another pandemic over the next few decades is 3 times higher. So when we think about COVID, that is certainly not our last pandemic. We've heard a lot about climate and health. When you think about climate change, 1.2 billion people will be displaced by 2050. And then the cost of that will be $2 to $4 billion. And with all the recent conflicts, we know conflicts are on the rise as well. And so this has had profound implications on our healthcare system, our healthcare workers, our infrastructure. And please do check out the QR codes for everyone's bios. But my first question is for you, Craig. So Craig, you've been working on the front lines of crisis settings in Guinea, Liberia, Sierra Leone. And can you talk a little bit about your work and how resilience has been showing up?
Absolutely. So my background, if you don't click on me, I'm an emergency physician. I still practice. I work in public health, and I'm on the board of Doctors Without Borders in the US. And so work in a lot of contexts of humanitarian crisis, disease outbreaks. When I think of resiliency, I think not of those places where I work only, but Columbia Presbyterian, one of the best hospitals in the world, where I was in March 2020 and saw more people dying a day of COVID than I did in West Africa in 2014 working in an Ebola treatment center. And so resiliency is not just a thing in developing or low middle income countries, it's an issue at home as well. I want to go and tie in what you were saying about health equity and defining that. When I think about health equity, whether it's in New York or anywhere I'm working, I think of 3 things. I think of affordability, I think of access, I think of quality. And there are 3 big issues that we need to fix with each of these. So with quality, 25 to 40% of the medications that are available in markets around the world, particularly in sub-Saharan Africa, are counterfeit or are not created to the standards that are necessary. This is a problem for antimicrobial resistance. It's a problem for tackling malaria, which will become an increasing issue with climate over the coming years. On the issue of affordability, look what we just went through over the past 5 years. I'm sure everyone in here probably had access to a COVID vaccine relatively quickly. It took a year, sometimes 2 years, for vaccines to get into places that needed them. We in the United States bought 3 to 4 vaccines per person. We're not using them, we're hoarding them, while other people, healthcare providers, 115,000 healthcare providers died around the world of COVID waiting for their own vaccine. And it's because countries were not able to afford them. Many places that had less means had to pay sometimes double the price for the exact same vaccine. And then the last issue I want to talk about is access. In 2014, I was working in Guinea, taking care of Ebola patients. At some point in this process, I was infected myself, came back to New York City where I fell ill. I had access to the best clinical care in the world. For that, I am here today. I had about 30 providers on call at any minute to take care of me. I was probably taking care of 30 people at any point when I was in Guinea in those Ebola treatment tents. When I got sick, I had access to basically any medicine that I could think of. The FDA offered to fly in a dose of a medicine that was apparently gone from the global stockpile, but they had a dose and they were going to fly it from Canada to me. I spoke with my provider. I said, I don't think we need it. I'm going to survive, so let it go to somebody else. 2 months before, Dr. Sheikh Umar Khan, who was a noted physician in Sierra Leone, got sick, got Ebola. As he was lying in a bed in his hospital, that medicine was across the hospital. He did not know it was there. He was not offered this medicine. He was not told about its existence. So the difference is not just quality, affordability, it's access. This person didn't even have access to the ability to take part in his own care, the agency. So when we're thinking about resilience, we're thinking about global health, we need to think about how we improve all of these things if we're going to, before we think about AI, before we think about the other things we'll talk about, we need to think about these issues first.
Yeah. So well said. Speaking of another conflict, Natasha, you've been working on the front lines of events in Ukraine, especially with the frontline healthcare workers. Can you talk about your work and what you've been focusing on in terms of mental health?
Thanks, Lily. Hello, everyone. It's a great pleasure to be here. I was here precisely in this room a year ago, and we talked on mental health, global mental health. Where are we from then? Lots of problems are still here. However, lots of partnerships have been built, and lots of issues that I personally was working on actually got a clear answer, and I'm very happy about this. To the question of global health and resilience. Do we think that global health and resilience always go together? Many people do. That's not the case. You form resilience, you build it, you cultivate it. You often fight for that. How do you actually do that? That was the question that our Ukrainian healthcare providers were asking myself and our wonderful Northwell team of psychiatrists and the team of global health last week when we were doing a stress first aid in Kyiv for 47 healthcare professionals. How do you build resilience? How do you make sure you do not fall apart? And global health and health system actually is glued together because the resilience is the glue. This is something that keeps us together and helps us to move on. The answer that actually John gave, how you build resilience, is with confidence and hope and kindness. I would add from myself that you also add courage and sacrifice. Because all of us are talking about resilience, but often should we ask ourselves, what are we actually ready to do to promote that resilience and build it and help countries in war, countries in hunger? It's all people. People are behind those countries. What are we willing to do for them? Are we willing to step out of the Zoom call and actually do something practical? And I know we are. One person can change a lot of things. Our healthcare providers in Ukraine have been fighting the third year of the full-scale invasion, the biggest war, not even a conflict, the war in Europe for the past 80 years. The largest humanitarian countries, Europe and the US, the whole world has been dealing with. The country that has been holding the fort for the whole civilized world. This is who needs resilience very, very much right now in global health. And right now, the Ukrainian healthcare providers have demonstrated amazing, excellent examples of resilience. Today, Ukraine has the best blood transfusion system in the world because of the war and how Ukraine learned thanks to partnerships and to the world best cases. Today, we have the best, which was just launched, the best mental health program for healthcare providers on stress first aid. In a couple of months, we're about to launch a program for war chaplains upon the request of the Ukraine armed forces on how to actually stay resilient and how to move on. So that's why I just want to say that this is super important. Everything is about resilience, and resilience is about people.
I think that's so poignant, and it's about the infrastructure. It's about our own human spirit. It's about our frontline workers and the mental health of everyone. And so, we spent a little bit of time about talking about crisis, but resilience is not always at the time of crises. It is also running our public health systems and how resilient they are as our communities change, evolve. So my next question is for you, Jone. We know how important resilience is in public health. Given your background in public health, can you talk about some of the interventions that you've been putting forward?
Absolutely. I'm Dr. Jonay Khaldun. I'm also a practicing emergency medicine physician, high five ER doctors. I worked in corporate healthcare, and I'm currently the president and CEO of the Public Health Accreditation Board, which accredits all of the governmental health departments in the United States. And so I struggle with this word resiliency. And I actually looked up the definition, what is bothering me about this word? And so when I looked it up, don't quote me on this because I'm doing this from memory, but it's essentially the ability to be able to withstand and recover from hardships, essentially. And when I think about that, this kind of recover as if the current state is good or something we should actually be aspiring to. And so I struggle with this word resilience because, and I'll speak from a domestic United States perspective, which is where I've done the majority of my work, I would argue that, the United States, we spend about 18% of our GDP on healthcare and healthcare delivery. And of course, many people know these statistics. we have some of the worst healthcare outcomes in the world. We spend the most money of any country in the world on healthcare delivery, yet we have the worst outcomes. And I would argue that, going back to public health, it's because we actually spend too much time thinking about the healthcare system. I'm an ER doctor. The reason why I primarily do public health is because very early in my career, I realized that I couldn't really, when someone comes into me and they've got a heart attack or whatever, and I need to crack a chest, whatever, it is way too late, way too late. I need to get out in the community to be able to understand what's going on and be able to fix those systems. So let me give an example of COVID. I just so happened to be the state health officer in the state of Michigan during the COVID response and led that response. And so in the state of Michigan, African Americans account for about 14% of the general population. Yet in the very beginning of COVID-19, we actually saw about 40% of the cases and deaths were African Americans. And let me be very clear, in case anyone doesn't know, that has nothing to do with genetics. There's no gene for the amount of melanin in your skin that says you should have a lower quality of life or that you should die earlier. Just what sometimes people don't understand that, so I just gotta say that. And so when you think about that, if you think about the recommendations that the CDC was coming out with early in COVID-19, make sure you should not share bathrooms. You should stay home. You should make sure you use your private car if you want to stay safe. So me, as a physician, yeah, I could, except for when I was in the ER seeing patients, I could stay home and do my administrative job. I could be safe. I could still make money, keep my health insurance, and be at home and be protected. But that's just out of touch. Our systems, before the healthcare system even comes into play, are not set up. When you talk about the incidence of chronic diseases, and how Black and brown people in the United States are more likely to have chronic diseases. And not genetic, it's because of lack of access to health care, to healthy food, to clean air, to affordable housing, to strong education, so you can actually get that good job, so you can get that good health insurance, which I would argue good health insurance still does not mean in the United States that you'll actually have access to good health care. I'm a doctor. It takes me 6 months to get into my primary care physician. So I would argue that the things that, and I won't get too much into, I feel like I'm taking up too much airtime here. I can go on all day. But I would argue that, and this is what we did in Michigan, the things that help improve health outcomes are the things that are happening in the community well before the next emergency, pandemic, whatever hits. Let's focus on chronic diseases and access to health care and making sure we have actually a primary care system so you don't have to wait 6 months with good insurance to see your primary care physician. Let's think about upstream before the emergency hits.
And I should have also mentioned, this is our third event with Northwell. And I tell you, when we put our events together, what we say is, we could spend a lot of time looking at the problem and admiring the problem, but what we really want to talk about is action and what's been working. And so I frame that up as I position my next question to you, Robert. Sustainability, and we talked about climate change, that requires a lot of shifts that are going to happen, people on the move, and the cost of incidences related to climate and health. And so given your role in sustainability, can you talk about how the private sector is contributing to building resilient health systems beyond the scope of their products?
Thanks so much. Super interesting question. And easy to build on what has been said here, right? Philips is one of the leading technology providers in the world, but I think we have come to see that healthcare systems is not a standalone system in the world. It is a system within systems, which you very eloquently described also, really how we distribute wealth and so forth. Even in Amsterdam and Holland, where I live, you see the life expectancy and the quality life here has really declined with the different postcodes if you just follow the metro. My wife is a midwife working in Amsterdam, seeing all parts of the population, but also telling me about the stress, the burnout, and so forth. So access and equity is not a problem of sub-Saharan Africa, so to say. It's everywhere, it's globally, and at the same time, it's very different also. If you think about it, there are still more than 4 billion people in the world that don't have access to any type of healthcare system. And if we make the link to climate, then we must state that the other 4 billion are emitting more CO2 with the healthcare system than all airlines in the world together. Nobody ever talks about it, right? And we see the impact of climate change on healthcare. So when my father was sick in his last years, a diabetes patient, and I could see that in Berlin, these heat waves hitting there, what that does to elderly people, and all of us have them in their families. And when they have to be hospitalized, how that adds additional strain and stress to people that have already been working double shifts and so forth and so forth. So I think we see that these systems are interlinked, and healthcare is not just only suffering from climate change, but also a major contributor to it. And I think with the responsibility that healthcare providers feel for the patient, I'm really blessed and glad to see that a lot of healthcare providers around the world also step up and say we cannot treat people and at the same time kill the planet. These things need to go in hand. We need to deliver care. If we want to really think about making healthcare accessible to everyone, we also need to make sure that we can deliver it within the planetary boundary conditions. Now, to your question, what is then a company like Philips doing? Well, one of the things, of course, is thinking about enabling hospitals to deliver, making care more accessible. We have a target on that. By 2030, we want to empower or enable healthcare for 400 million people in underserved communities, which is really a major driver also for thinking differently how healthcare is delivered, what role digitalization can play, but also you don't solve that with technology alone. It's really about reimbursement systems. It's about building capabilities and capacity and so forth. Not going into that. On the climate side, of course, it's really aligning your entire innovation roadmaps with science-based targets for scope 1, 2, and 3. We have been operating carbon neutral since many years now, but the majority of the emissions are, of course, in our supply chain and downstream. So really going into the hospitals, trying to understand together with the physicians where actually the emissions are. We published about it a lot. We did quite a lot of studies also in different continents and states working with leading care providers around it, but then looking for practical solutions. Let me just wrap up with 3, I think, practical steps to illustrate what I mean. Of course, there's a lot of energy going into hospitals. They are very energy intensive houses. So you can have a discussion around energy efficient equipment, but I think that's the bare minimum. I think it is more interesting to also think about and engage on top of that about how, for instance, diagnostics is provided as a service through circular means so that you can address the embedded carbon, all the amount of energy that's required to provide the materials for the hospitals, how you address waste and so forth. And I think the third level, and that's really interesting, is where you touch and work very closely together with doctors and care providers, is thinking about how you optimize care pathways. For instance, if you provide better diagnostics or allow better diagnostics, you can avoid double scans. You have the impact per scan. If you can find out how the condition of a patient is potentially deteriorating, you can detect these early signals with AI. You mentioned that earlier. Then you can intervene before he or she has to come back to the hospital. So there's a lot of things that you can do to really optimize how care is delivered in the existing systems also to get the footprint down. So I think these things are very interconnected.
Can I just quickly react to the things that you both just said? You know, Janae, your point about let us not get back to what our baseline is, and I don't think that's unique to the United States. We have healthcare challenges everywhere, but it is very common for us to think about that unidirectional flow of knowledge and solutions. We have the money, we have the ideas. Who here has been to Rwanda? Yeah, a lot of folks. Rwanda's an amazing place. And nearly everyone in here today was alive when 30 years ago Rwanda was torn apart by genocide. In 3 decades, Rwanda has built a healthcare system by Rwandans with public, with private support that was able to successfully manage a Marburg outbreak all on its own. External support came in, CDC came in, WHO came in. There was equitable access to investigational countermeasures, vaccines, and treatments through the Sabin Institute, IQVIA, who I know is speaking yesterday. This is unbelievable. I very, very rarely, as someone that looks at the history of health and medicine, I very rarely say the word unprecedented, but I've used it here. And this is where resilience is, where in 30 years you can turn around from being one of the most dramatically and saddest and hardest places where there is no healthcare system at all, to be able to manage a threat that has stymied many other countries, including places like the United States, is unbelievable. And I think there's a whole host of lessons there. Your talk about community. What did Rwanda do? They built from the community up. In the rebuilding process of the genocide, they built in health systems and health solutions that were informed by community members. They thought about access. They thought about using support from the Global Fund, other things created here in Davos over the last quarter century to say we need to make these investments and make sure that 33 cents might be too expensive for someone to go to the physician, even if they have, I think 95% of the country has healthcare. Okay, fine, let's find a way to cover those costs for 1.5 million people, so that you have community access, you have a focus on rural populations. You're thinking about, even amongst that population, the most marginalized, the most disadvantaged. That is why that system works. That is why it was able to do something in the span of just a couple weeks that in many other places would not have worked.
Janae, a question for you. When we think about health equity and the role of data, data is very empowering because it can highlight what the inequities are. And I'm just curious how you've been using data-driven solutions to also guide some of your work.
Absolutely. You know, data is incredibly important when it comes to whatever the intervention may be. You need to have data, but there's a couple points I want to make there. One, we often see in the healthcare space, especially in the health equity space, that people say, oh, I don't have enough data, I don't have all the robust data on race, ethnicity, sexual orientation, gender identity, therefore I can't do anything. Well, data is just meant to be a signal. We are never, I've worked in public health for a while, we are never going to have robust, complete data on every single thing in real time. I shouldn't say never, maybe I should be more optimistic, but we're not gonna have it anytime soon, I don't believe. And so for us, it's about how can we leverage the data we have, how can we democratize the data, right? How can we actually make sure that, you know, everyone in this room, you're in Davos, therefore you're probably a leader in an organization, you may have access to a lot of data, but how about we, to your point, give that data to the community? Show the data to the community, ask them to ask the right questions of the data, and let them interpret the data, and then be able to design the solution. So I'll give one example. When I was the director of the Detroit Health Department in Detroit, Michigan, one of the worst infant mortality rates in the United States. And so the mayor, you know, God bless him, he said, Jonee, I want you to fix infant mortality. That's what you're going to work on. I want to see like weekly infant mortality rates. I was like, Mayor, that doesn't work like that. You can't get them weekly. But I hear you. I'll work on it, right? And one of my colleagues in the room here, Dr. Renee Kennedy, also was part of this work. And so we said, okay, so we're at the governmental health department. We don't have much of a budget, but we have a lot of data. We have a lot of local data. We have a lot of state data. So what do? We said, okay, there's a lot of folks in Detroit, organizations, public, private sector, who are working on infant mortality, have been doing it for a long time, unfortunately still seeing the same poor outcomes. So we said, okay, let's bring folks together, bring the public and private sectors together. Let's stop competing. This is something I had to learn early in my career. Let's stop tripping over each other. We may, oftentimes organizations are working in the same communities, don't know who each other is impacting. We're not looking at data, we're looking at, oh, I served 50 people in my program, high five, they did well. But wait a minute, who else is serving that population? Who's looking at the data? What populations are we actually missing? And so back to Detroit, so we brought folks together, we looked by zip code. And I annoyed my state colleagues who had all the data. I wanted zip code level data. So in some communities in Detroit, it was preterm birth. Others, it was right before they turned one. It was sudden infant death syndrome. It was a safe sleep related issue. So we actually looked by zip code, and then based on community input, we actually designed interventions at the zip code level. In some places it was the pastor. So we actually designed things in certain ways. We brought together the healthcare systems that had their own kind of things on the side. My health department, we determined that there was a lack of access to healthcare, so we designed a free program for people who did not have insurance. We brought in a rideshare service because in Detroit, you may not know it, Detroit does not have a robust transportation system. It's almost like a rural place, even though it's a major city. And so when we have focus groups and talk to folks, we don't have transportation. Okay, you get a free ride. So we did all of this, we put together this system, and lo and behold, even though it was quite fragile, Detroit in 2019 had the lowest infant mortality rate ever recorded in the history of recording infant mortality in the city of Detroit. And it was fragile. It was not about me. It was not about one particular organization. And then COVID came, and again, it was very fragile. But what happened in that instance is that we shared data, we got very granular, we understood what was needed in each community, and we stopped competing with each other. We were actually referring, one organization referring to another organization. And that's what we need to do, stop competing with each other, share data, make sure we democratize the data, and then be very intentional. And it helps to have a mayor who wants to have weekly infant mortality rates.
And if you haven't seen the Robert Wood Johnson Foundation, if you live in the United States, you can put your zip code in and it can tell you your life expectancy. And so there's something very real when you look even within not too far of a vicinity on what life expectancy looks like. So it's very neighborhood dependent. I'm going to have one more question for Robert, and then we'll go to all of you for a couple of questions. Robert, you talked about opening up other markets, roughly 400 million people. And so can you talk about that experience, lessons learned from around the world, and where you're seeing similarities and also differences?
Yeah, thanks a lot. So that's fascinating and also complex, right? I mean, we have been around for 140 years or something, and got big with selling big machines to very well-equipped hospitals that prefer to do academic research. So now you are confronted with a totally different problem. How do you address that? How can you leverage, let's say, a trend of digitalization in healthcare, but how to drive innovation beyond the product innovation and really say it's about how care is delivered. There's a lot of things that need to happen in an organization before you can do that, actually. And we did that actually, and we are still doing that on 3 different horizons. The first one is we have a lot of equipment that's out there that's not always utilized. I mean, there are hospitals that have fantastic equipment, but are only using it 20% of the time, which is a shame. So that's also about asset utilization, referrals, working with hospitals and care providers that the right people get access to the right equipment. One of these things that we have started in India, for instance, is screening for people with heart disease to get them to diagnostic centers and then refer them to tier 2 and tier 3 cities to get image-guided therapy for catheters and stents and these kinds of stuff. So now, when we started that 6 years ago, I think, or so, we had this discussion, can we do that? Access to care, this stuff is expensive. Until we had this pivotal moment where we said, it's not about the cost of equipment, it's about the cost of care. So can we build effective referral streams? And we have installed more than thousands of these IGT, image-guided therapy systems, cath labs in tier 2 and tier 3 cities in India since. So that is something that seems to be working. I think the second one is really finding and developing also new models of reaching out to communities. So really building the stuff. Let me condense it for the sake of time. But I think the other 2 important points that I wanted to make is really building groups of people and alliances that bring different assets and capabilities to solve a given problem. For instance, we have set up a group that's called the Digital Connected Care Coalition. Now, everything is digital connected these days, but it goes 5 years back or so, where we said, can we build together blueprints that are scalable and shareable to solve a given problem? One of the projects that came out of it is VODAN, the Virus Outbreak Detection Network in Africa, where more than 14 countries are participating in it, which is fantastic to share data and prepare on these kinds of things. So that seems to be working because you have people that bring technology, connectivity, clinical data, money, and so forth. So it's a given problem that we try to solve with different capabilities around it. And then the other thing is also working with the Philips Foundation, which has an investment group where we invest in social entrepreneurs. I saw one of them in the room here. Because social entrepreneurs really have this drive. I think they can build, also contribute to what's said bottom up, basically, in these countries, build resilient systems and ecosystem, not making them, the countries, more dependent on the systems on aid from foreign, but really building it bottom up. Let me stop.
Yeah. The impact investing angle. All right, so let's open it up for a couple of questions. Please raise your hand, and my lovely colleague will come around, and we'll get a couple of questions in.
So thank you all very much for your thoughts and insights on this. Really good to hear, especially your experiences. I'd like to ask a little bit about patient or just individual education regarding healthcare resilience and equity. Us doctors know that when someone is educated or have a better understanding of the condition that they're facing or they could face, they have a better appreciation of it, they're more likely to be compliant, they're more likely to take measures, either preventative or secondary care after they've got the condition. What has been your experience with that in your communities? What would you advocate, and what evidence do you have that helps and works?
I think it's incredibly important to, and I teach medical students and residents, and oftentimes when they're discharging a patient, you shall use all this medical jargon and then just kind of print out their 20-page discharge summary and just give it to the patient. Oh yeah, bye. You really expect they're gonna do what they're supposed to do. And so I think it's important that the healthcare community actually thinks about organizational health literacy and take the onus off of the patient. We're supposed to be, I went into healthcare because I want to serve, right? Not because I want people to understand all my medical jargon. So I think the onus is on the healthcare community to actually be able to simplify their language and make sure it is our duty to make sure our patients understand what their disease is, how they can prevent progression. I would also say, I'm an African-American woman. During the COVID response, I was on TV just about every single day, while I was also practicing in the emergency room in the city of Detroit. And it is not lost on me, and my patients still are you Dr. J? I was Dr. J in Michigan. It's not lost on me how important it was to the city of Detroit, which is 80% African American, that there was an African American physician on TV every day talking about vaccines and, get the test, and we're not trying to kill you. It was incredibly important. And I've had patients tell me, I didn't care what those other people were saying on TV. I knew that you were one of us, and I trusted you, and that's why, I wore my mask, and I think you saved my life and my family's life, and you decreased my anxiety. And it's not about me. It's about what I represented when I was there. And so the messenger is incredibly important. And I would say that in the United States, we have a real problem with lack of diversity in our healthcare workforce, which we need to also think about. Not just physicians, I can go on, but community health workers, nurses. We need to think beyond the physician workforce and think about the entire healthcare workforce and what that means when it comes to educating our patients.
To this, that was a very good question, and that's perfect. I totally agree. It's wonderful when you can prepare your communities, your students, your patients. But also we have to remember that very often the resilience is formed when something bad happens, the turbulent times happen. You do not have time to think through, to prepare yourself, and you have to start acting immediately. And that's your ability to adapt, your flexibility. That's your internal resources, external resources, and that's when the partnerships come together. That's when the motivation and inspiration come together, and of course, the practice and the model. I totally agree with you that it's very important. The messenger is very important, and people do tend to trust if the messenger is one of them. I've heard this everywhere in Ukraine and all over post-Soviet Union. That's the total truth. But I just want us to remember that sometimes, often, we cannot prepare for that.
And I just want to say, because it's this week in Davos, and if we don't mention AI before the end of this panel, I think we all spontaneously combust. I want to say, I see some folks that I was speaking with this morning about AI in healthcare. I came to Davos last year as an AI skeptic, and I'm now much more middle ground, and I think there are targeted places where it can be incredibly useful. I think this is one. I think we can train physicians. You and I can beat our heads against the wall about telling people to talk to patients in a way that makes sense, that they understand. The reality is that we just don't do a good job of that. So I've seen really promising work on translating discharge instructions or really complicated health information into a 5th grade reading level, which is probably the level that many of our patients are at. And so I think that there are solutions that can be integrated that can be helpful. And so I want to make sure we talked about AI at least once. Yeah.
Good afternoon. My name is Dr. Sophia George. I'm president of the University of the Virgin Islands. And so one question I had, great panel by the way, is what do the Colombians call those care blocks in Spanish, just so I can get a context around how you were able to destigmatize it. And then I know that Cuba has some similar supportive preventive healthcare models, similar to what was discussed having in Bogota. So my other question that leads me to then is, tell me a little bit about your thoughts on accountability of healthcare providers in this country. I'm a healthcare provider myself, so I'm not throwing any shade. As well as accountability for those payers, the insurers, states, countries, and not just patients. I know patients have their part to do, but there are also barriers, as we all know. And then you mentioned the partnership and the framework that you're using, with Robert Johnson Foundation, which is essentially about creating a culture of health, which I'm a fan of. So how do we do all our part across the globe in creating a better culture of health in partnership, and what other strategies, what we think about in helping to create that culture of health?
Well, maybe a different perspective. I happen to be also engaged in the metropolitan region in the Netherlands, the metropolitan region of Amsterdam. So it is a different setting, but in terms of creating culture of health, one of the things that we have worked with between academia, the heads of the universities are part of that, between civil society, the government, and businesses, to really think about what do we want the city to look like in 20 years from now? And we have come to the conclusion that GDP is an awfully bad measure for that. So agreeing on a common understanding of broad welfare, including healthcare, and setting specific targets and saying, okay, we want to ensure that average health expectancy is increased with at least 2 quality-adjusted life years. across the city. And then working backwards, what does it mean? How do you translate it into a preventative program? What can we do on cardio healthcare in that space? How can you use technology, but how can you use also existing social networks, organizations to increase health literacy and so on? I think that's an approach that brings together, let's say, a lot of engagement and interest from different groups, but also provides a little bit of a top-down framework for accountability and keeping track on it, and providing, let's say, political cover and economic interest where that is normally caught up in just increasing GDP, let's say.
I mean, I'll just add, having worked in the U.S., a payer in the past, I would say that, unfortunately, the U.S. healthcare system is a for-profit, it's a business, right? And so payers will do those things that help them be profitable. And if often it can be related to health, but if the improved health outcome is not related to making money, then the accountability is not there. So I would say that we need to hold payers accountable. Then folks like in the United States, CMS, that kind of oversees Medicaid and Medicare, largest insurer in the country, needs to, and we won't get into current politics here, but should really be thinking about how do we hold the broader healthcare system accountable for identifying and decreasing disparities. What if payers didn't get paid if they were in a community for a certain amount of time and the healthcare outcomes for the broad community did not improve? What would that mean, right? And so I think there's a lot that, a big role that government has to play to hold organizations accountable, particularly in the United States.
Hi, everybody. Josh Ruxin from Good Life Rwanda, also a Rwandan citizen, actually. Just two things I wanted to address. I mean, one is, yes, Rwanda's done an amazing job on its public healthcare system. And now today, we actually have a different problem. We have people who are starting to earn money in the private sector, and they're leaving the public healthcare system and getting lower quality care in the private healthcare system. And that's something we're trying to address. And then, Craig, just to your point, you are absolutely right. Rwanda did everything correctly. And the US government decided to put travel restrictions on Rwanda, which it actually ratcheted down just a couple weeks ago. But still, if you go on the US State Department website, it'll say, if you're traveling to Rwanda, beware of Marburg. So it's really difficult, as Dr. J noted, not to bring politics into this, because politics are impacting this. Politics are impacting equity around the globe. And when countries do everything correct, and then get knocked down and have their tourism industry impacted, that has further public health impact. So anyway, thanks for shining a light on Rwanda.
Well, thanks for pointing that out, and Josh, all of your work that I know you've been doing in Rwanda for a long time. You point out the Rwanda example and how the U.S. did come out. And actually, I was quite impressed with the U.S.'s reaction this time, because 2 years ago, I yelled at the White House for doing something different in that they came out with travel restrictions on Uganda without at the same time saying, this is also what we're doing in the country to help. I said, if you're going to do one, you need to do the other. And we saw what happened then. There was an attempt to try to cover up cases for quite some time. We weren't getting the transparency. Look what's happening right now in Tanzania. A week ago, there was reports of a Marburg outbreak, and then there wasn't. And now the head of the WHO is not only having to manage the U.S. withdrawal, but is trying at the same time to coax the Tanzanian government for exactly this reason. Tourism is a massive part of this. Countries are not stupid. Look what happened to South Africa the day after the Omicron variant was reported. Hundreds of millions of dollars were impacted for no good reason. We know that at this point, the Omicron variant was brought into the African continent more than it was exported out, because it was in places like London, it was in Brussels, places that weren't affected by travel bans. The way that we think about and externalize threats that's coming from people in places over there, while undermining our own health systems, is the surest way to continue to remain unprepared. Pulling out of transnational organizations. I work for Doctors Without Borders. I have no shortage of problems with the World Health Organization. But let me tell you, do we need it more than I think people are unfortunately going to recognize in the next couple of years. So thank you for pointing that out. We need to think about what are the lessons from Rwanda. And this is where everywhere I go, I say Rwanda's not perfect. There were actually some issues with the way the outbreak was managed, with the survivors. But like it's not going to be perfect, but we need to highlight these wins. There are very few of them, and very often we overlook them in places when they go well because no one in the U.S. had to worry about it. It wasn't splashed across the front pages of the New York Times that we have Marburg in New York City, whatever it is. People don't worry. People don't know the stakes. So thank you for pointing it out.
Well, that went by fast, quickly. I have one last question for our panelists. And I think of all of us as stewards of our healthcare system. We all live in communities, we're part of countries. What happens in one side of the world, we're all interconnected. We saw that with COVID-19. And so I don't think the onus of building resilient healthcare systems rests on our healthcare infrastructure. I think it rests on all of us. And so a question for you all, and Natasha, maybe we'll start with you, is as we end this session, final thoughts on how do we continue to prioritize resilience? We know more crises are coming, unfortunately. Climate change is coming. But any parting thoughts or advice as people go back to their own communities in building resilience?
I would say, that's okay, it's working, thanks. I would say we stick together and we work together. We continue to inspire each other and motivate each other and pay attention to the most urgent needs of our own communities. And also, if we can help other communities, we reach out to them as well and go there. And I think the question is, how willing are we to get out of our comfort zone? And I think that's what all of us should do. The more we get out of the comfort zone, the better the world would be.
I'll just quickly say resiliency requires respect. Respect for others, respect for this issue of equity. It means more than just a tagline at Davos. To go back to my earlier example of Ebola, there are 2 approved Ebola treatments, neither of which I received because they didn't exist. The US has put $750 million into the development of 2 treatments that now exist. One is owned by Regeneron, one is owned by Ridgeback. They have the full licensing. They sit in the United States Strategic National Stockpile. So anytime that there is an Ebola outbreak, countries have to go begging and pleading to the United States government as opposed to there existing a stockpile like there is for Ebola vaccines. So we need to think about resiliency requires respect. Respect to say we're including people in this. Respect to say when people need us and need the resources that we have developed that we're willing to share with them, not asking people to come to us to beg for them.
Yeah, so I think that's a deeply human thing that both of you pointed out. Let me add to that, not because I think it's more important, but I think it can help. Technology can also help indeed, but only if it's the innovation is not in technology itself. It needs to be developed with the communities, with the practitioners in the field to be meaningful. And then it can help to increase resiliency of the system and supporting the people that are actually connecting and facing it every day. Thank you.
I think it's a similar theme here. I would say whoever you are, whatever organization, whatever title you have, when you go back to your office, ask yourself the question, how is my ego showing up in the work that I'm doing? It could just be your next meeting. Do you actually have to be at the head of the table at a meeting? Do you have to, because you have the money or whatever, do you have to be the lead of whatever the thing is that you're trying to roll out? Ask yourself that question. How is my ego showing up in this next meeting, let alone your big program, okay? And the next thing is, ask yourself the question, what group is being left behind? Just pause. You don't have to don't make it a big thing. Just ask yourself the question, what group might be left behind in the work that I'm doing? I don't care if it's AI, whatever the program is, who's being left behind? I think we're not even pausing to even think about it and ask ourselves a question. If we just started with that, I think we'd see more progress.
All right. Well, thank you, everyone. If you can help me thank our wonderful panelists. So we will have a short break now for 15 minutes. There was a comment made that how do we not talk about AI at a Davos session? But we have the next session focused on technology, and we'll have plenty of opportunity to talk about that. So we're on a break for 15 minutes. Thank you, everyone.